This lecture actually grew out of the shock that our group experienced, unfortunately, last summer when the AOA unceremoniously threw us out. They decommissioned us. And so we have been diligently working to form a new subspecialty called the American Osteopathic Society of Integrative Medicine. And one of the challenges is that we need to show that what we're doing is distinct from quote unquote conventional medicine. And one of the easiest entities that actually I found in my practice is the entity known as Hashimoto's thyroiditis. One of the things that I did when I gave this lecture, I gave this lecture to the Nevada Osteopathic Medical Association. You'll see there, it was in August of last summer. One of the things I did was I handed out blank 3x5 cards and gave them pens, and I asked them. And remember, these are all seasoned practitioners. These aren't medical students. These aren't residents. I asked them what Hashimoto's thyroiditis was, and you wouldn't believe the answers. So I hope you all know what it is. If you don't, we're going to define it as hypothyroidism due from an immune either deficiency or immune excess. And they didn't know that. Half of the answers were hyperthyroidism. So it was quite shocking. Oh, it was a CME credit. I don't have any financial interest in anything. Here are the objectives. I did a rather extensive comparison between integrative and conventional medicine. I'm not going to do that here. I talked about the DO distinction. We'll talk about the meat of the matter, the heart of the matter. Hashimoto's thyroiditis as a model of integrative versus conventional medicine. We'll talk about both, and we'll point out the distinctions between them. We'll make some definitions, and we'll give you some conclusions. And at the end, I'll always give you a 1 or 2 slide summary, and then all of the references that we have down here are usually all in one place. I'll give you just a brief. I found this definition of integrative medicine. I found this on Andrew Weil's website. And an individualized, patient-centered, evidence-based approach to health. It addresses underlying causes of disease and promotes optimal wellness. Patient evaluations can include genetic, biochemical, and lifestyle factors. We address root causes of disease versus symptoms. And I think these are things that we should all be doing all the time. And somehow this is considered so controversial. It creates a uniform method of identifying the complexity of disease. In my practice, we've developed a system where we approach things the same way for every patient, so that we don't miss anything. I call it the hormone-centric lens, or the hormone-centric way of looking at medical care and life itself. A single condition can have many different etiologies, and a single etiology can have many different conditions. And again, that was from Andrew Weil's website at the University of Arizona. Integrative versus conventional medicine. Health is an optimal balance of resilience and integrity of the mind, body, spirit, and their interrelationships, versus health is an absence of disease. Disease is symptom and individually based, and an imbalance of body, mind, and spirit. And in the conventional, it's we have organs that are dysfunctioned and disrupted, biochemical symptoms or undesirable symptoms. It can involve more than physical processes. It can the brain can help exert healing effects on the body, and in conventional medicine, it's usually it's only the physical processes. Treatments can include conventional medical models, in addition to evidence-based natural healing practices and the patient's inherent capacity for healing. And I'm a DO, and that's what the DOs ascribe to. Treatment includes drug, surgery, radiation, electrical treatments, medical devices, nutritional and lifestyle interventions, and that's, for the most part, usually done with a wink and a nod. So we're going to talk about Hashimoto's thyroiditis. I'm going to give you some definitions. We're going to sort of start almost at the beginning for thyroid disease, because it's poorly understood, and patients really don't understand it. I have patients who come into my office and say they've had thyroid disease for 30 years. And when I ask them what the thyroid does, they look at me like I'm, with a blank stare. So what does the thyroid do? And you have four words, and the first two are "it's your." And this is the way I approach it to patients. This is what I ask them, and you'll get all sorts of answers. Metabolism and it takes care of all sorts of things. But I tell them you only have two more words. And so again, this is what I like to tell the patients: it's your gas pedal. It tells your body how fast or slow to go, and that's what it does. And it encompasses every system of the body. The thyroid produces two major hormones: T3, thyroxine, and triiothyronine and thyroxine. But it also produces two other thyroid hormones, T1 and T2. The T stands for tyrosine, not thyroid, and the number stands for it reflects the number of iodine molecules attached to the tyrosine, or the protein backbone. It also produces calcitonin and a little bit of magnesium. And so if you look at the side effects of, say, just T4, levothyroxine, you will find that it will be in there. It will say osteoporosis, thinning of the bone, and muscle pain, and all things having to do with magnesium. So T3 and T4 are the major regulators of growth and rate of function. But there is a T1 and a T2. We don't really know what to do with it, so we just kind of ignore it. I've been seeing a little bit of literature about a T2 syndrome. I'll have to get back to you on that. Maybe some of you know something about it. But so I've been seeing a little bit about it. So here are the chemical structures of tyrosine, which is the major protein that I told you about. This is the backbone. And I liken this to sort of like a stick figure. This is the head with no arms. Here's the body, and here's the legs. And the number of iodines. And remember, there's a 1 and a 2. This is 4 here. This is T4. This is 3. This is the part that does the work. This is the active part of the thyroid. And we need to know what that is. But there's another part here. It's called reverse T3. And you can see that the open iodine is upside down. This is inert, and it does not work. And this is important to know. And we're gonna talk about that in just a few minutes. But if you order a total T3 in your lab panel, you're not going to know whether it's the part that does the work or this inert part. And so, quite frankly, to me, it could be high, it could be low. Then you know that it's high or low, but you don't know what portion it is. So we want to know what the free T3 is, and you want to know what the reverse T3 is. This is the part that does the work. This is your store unit. 80% of the thyroid is in this form, in T4. And the rest is in T3. The thyroid, any single day, only produces about 20% of the daily requirements. It makes about 100 micrograms of T4 and 30 of T3. The majority of the thyroid molecule comes from a process known as deiodination, and it's a natural conversion of T4 to T3. And in a conventional medical model, that's what the endocrinologist sort of banked on for thyroid to function properly. But by the time your patients get to us, a lot of times that conversion just doesn't happen and it doesn't work. And so here are the symptoms of hypothyroidism on the left, hyperthyroidism on the right. Our goal is to make your patient Goldilocks, not too much, not too little. 98% of the time, when you have a thyroid issue, it's going to be hypothyroid. So that's what we're going to concentrate on. And what you find is you get dry skin, dry hair, fingernails crack and break, constipation, can't lose weight, cold all the time, tired all day long, slow heart rate. You can get a goiter, you can get an enlarged gland, puffy face, and dry hair. Hyperthyroidism, you're going to get patches of hair loss. You get that bulging eyes. You remember Marty Feldman from Young Frankenstein. He had the bulging eyes. He was hyperthyroid. You get sweating. You get, again, a thyroid enlargement. You get the opposite of hypothyroidism: rapid heart rate, diarrhea, weight loss, moist palms, soft fingernails. like I said, it's pretty rare when a patient comes in with this. A lot of times we'll have patients come in that are hypothyroid, that had a hyperthyroid crisis 6 months to a year before, and either they were seen by somebody or they ignored it. And what they present with now is sort of a thyroid burnout. So this is how the sort of the whole thyroid system goes around. There's actually a thyroid releasing hormone produced in the hypothalamus, which is sort of above this here. Thyroid stimulating hormone, which is the only lab test that the endocrinologists say you're supposed to look at, is produced in the pituitary gland, and it's our detective. It detects how much or how little thyroid is in your system, and it makes adjustments. And so if it detects you don't have enough, it's going to make more. If you have too much, it's going to make less. And so that number that we get is an inverse. So if we get a high number, that means you're hypothyroid. If you have a low number, you're hypothyroid. It will convert into a T4 and T3. This is the part that does the work, like I mentioned before, and it requires iodine and selenium for that conversion to happen. If there's some disruption, and 90 to 95% of the times it's due to too much cortisol due to stress hormone. And so we get that reverse T3. So we use the reverse T3 as our first sort of line of defense, or our first inkling into cortisol or stress hormone. It's about 90 to 95% correlates with the saliva test that you may do, the 4-point saliva test. This costs about $8, and the 4-point saliva test, which no insurance will pay for, will cost anywhere from $200 to $250. So this is pretty reliable. We like this, and we'll go over the labs in a little bit. You also need some nutrients for the whole system to go around. And so we need some zinc, we need that protein, you need that tyrosine, you need selenium and iodine, a little bit, you don't need a whole lot. Vitamins A and D for cell communication, and EFA to increase metabolism and get the thyroid functioning the way you want it to. So when you go and buy a thyroid supplement, a thyroid support supplement or something like that, any one of those, it will always have that tyrosine, that protein in it. It usually has a micro dose of iodine, and usually 150 to 225 micrograms of iodine. The daily requirement is 12.5 milligrams, and that's too much. That will probably give us a hyperthyroid issue. Selenium, 200 micrograms per day. Vitamins A and D. Vitamin D, we want to get at our blood level of 50 to 80, and a little bit of fish oil. And we measure C-reactive protein to measure that. So what happens when the thyroid goes bad? In the conventional model, basically it's either a nutrient issue, which again, it's kind of looked at with a wink and a nod, and a failure to convert T4 to T3. In the integrative model, we're going to look a lot deeper. We're going to look at the immune system, and with the immune system, you're going to look at what the patients are eating. You're going to look at their toxin exposure. You're going to look at infectious diseases. You're going to look at the HPA axis, iodine deficiency and insufficiency, and certain medications will slow the thyroid down also. Here's your workup. You do it, the physical, history physical. In the conventional model, you do a TSH. You may or may not, quote unquote, reflex to T4. According to the American Society of Clinical Endocrinologists, the TSH is the single best screening test for thyroid dysfunction for the majority of patients. Normal is 0.45 to 4.5 microimmune per liter. The TSH, like I mentioned before, is produced in the pituitary gland, and it's your detective. It detects high or low circulating thyroid. If you have a patient that has a TSH of 4.5, and however you get their TSH down to 0.4, all things being equal, the patient will actually experience about a 12-pound loss in weight. There has been some noise, and I know in some circles, the TSH, the top number is now 3.0. Remember where those numbers came from? Like this, the 0.40 to 4.5. That's basically 2 standard deviations of which is 95.4% of whatever we're measuring. That's where all of these numbers came from. Sometimes they get a little bit skewed. Back in the day, a total cholesterol before there were statins, the top number was 350, and that was the two standard deviations. That was the top number. Back when in the 70s, when the lab industry sort of took this as their quote unquote normal. The T4 is the store unit. I liken this to those of you who are old enough to remember a lady named Imelda Marcos. She was the wife of the president of the Philippines. In the mid 80s, there was a scandal. Newsweek reported that she had 3,000 pairs of shoes, and she showed her closet. And so the T4, which is the primary hormone produced by your thyroid, is actually just the store unit. It's sort of like Imelda's closet. Normal values there, 0.7 to 1.53, optimal 1.15 to 1.53. And so again, I discuss Imelda Marcos, which as we get older, the younger generations never heard of her. But the part that does the work is the shoes that she was wearing, and the store unit which is our T3, and the store unit, which was the closet, is T4. Now, just think about, just for a minute, what levothyroxine is. Remember, the endocrinologists tell us the only thing you're supposed to use is levothyroxine T4. Levothyroxine is just T4. Remember what I told you the thyroid produces: T1, T2, T3, T4, calcitonin, and a little bit of magnesium. And so if we're just giving you T4, you're really sort of missing the mark. Here's some normal lab values for the T3, T4, TSH range. And this is a way to sort of classically diagnose hypothyroidism at primary and hyperthyroidism at primary and a pituitary gland. So high TSH with normal T3, T4 is a primary hypothyroidism. A high TSH with low T3, T4 is hypothyroidism. Low TSH with normal T3, T4 is primary hyperthyroidism. Low TSH, high T3, T4 is hyperthyroidism. And if everything is low, it's usually something in the pituitary gland. Here's a schematic of the lab values. And I show the patients this. I show them where they are. We say we get a TSH of 3.8 and a free T3 of 2.4. And you can see that they match. I had a patient today. His TSH was 6.83, which was, again, remember, that's low, but the TSH was 3.7. So even though he was, the detective tells us it wasn't working, he was getting more than enough thyroid medication. Here are, again, remember, 0.4 to 4.5 is normal, and we're supposed to just leave them alone. Here are quite a number of increased disease risk factors with that normal zero, actually, this is between 1.8 to 3.3. And it goes all the way from autoimmune issues to blood pressure issues to cardiac disease, to cardiovascular disease, to weight gain, to severe forms of depression, even at just 3.3. And here are the references over here. So, this idea that one of the ways when I talk to the quote unquote conventional doctors, I'll say, well, here's your thyroid lecture. If the TSH is greater than 10, give them Synthroid. If it's 4.5 to 10, we'll give them Synthroid if you have those symptoms that we mentioned, the dry skin, dry hair symptoms. If it's less than 4.5, the patients have psychiatric issues, send them to psychiatrists. That's basically what they tell us to do. Here are the labs that we're gonna order. We're gonna order a TSH, a free T3, a free T4, that reverse T3. We're also going to get a 25 hydroxy vitamin D at adequate levels between 50 and 80 will aid a number of hormones, including the thyroid, also growth hormone and cortisol, stress hormone. We get on everybody the thyroid antibodies at least once. Where I live, it seems to be an epidemic here. I'd say 1/3 of the patients who come to my office with whatever symptoms they do, we do this on everybody, and 1/3 of them have positive thyroid antibodies. I don't know. I'm in Reno, Nevada. We're downwind from where they used to do nuclear testing, I guess, in the 50s and 60s. There's a lot of mines around here. I don't know if that has anything to do with it or not, but it seems to be an inordinate amount of thyroid disease here, especially from the immune system. You also want to know what the ferritin level is. You need iron. You need iron stores to build that tyrosine, that protein backbone, and B12 and folic acid. So this is just for your thyroid. This is the lab that you want to do. Remember, the conventional doctors told us TSH and maybe reflex to T4. That's all you need to do. Reverse T3, we mentioned that before, is an inactive form of T3. T4, remember, converts to either a T3 or a reverse T3. Reverse T3 is not functional. It's a potent inhibitor of the conversion of T4 to T3. And a reverse T3, the lab value is 9 to 25 is considered normal. We start seeing symptoms on less than 15. We can also do a calculation of a free T3 to reverse T3. We want that to be greater than 20. And that's that. I'll tell you about that in just a bit. And that has to do with brain function. Causes of reverse T3 elevation, 90 to 95% of the time, it's an excess or deficiency in cortisol, stress hormone. Some beta blockers can do it. Iron deficiency can do it. Diabetes can do it. But most of the time, you can pretty much rest assured that we have an abnormality in cortisol when you have an elevated reverse T3. We're going to get thyroid antibodies, TPO and thyroglobulin antibodies. You need to do both because sometimes one will be positive and the other one will be negative. So you need to do both of them. Either one of them that are positive by 1 point is indicative of an immune issue. And there are some practitioners that will say any type of measurement, the measurement should be less than 2 or 0 to 2 or not there at all. Any measurement is indicative of an immune issue. I don't want to quite go that far, but usually if the TPO and this is not CME, so I can mention LabCorp, you'll get less than 34 is considered normal. So if you get it less than greater than 20, that you're probably skirting into the immune issues territory. Now, in the thyroglobulin, usually it's less than 4 is considered normal, and you get anything higher than 4. You can be assured that, we got some immune issues going. For Graves' disease, which is the autoimmune hyperthyroidism, we get that TSI, and anything greater than 80 is usually considered some sort of hyperthyroid issue. You don't see that very often. B12 and optimal is greater than 800 picograms per milliliter. Ferritin, 90 to 110 is kind of our sweet spot. I've seen it as low as 6 and 7 with the immune issues with the thyroid. And again, vitamin D, 50 to 80 is our optimal. Normal is 30 to 100. Some other tests, you can get a 24-hour urinary iodine. Iodine, as you know, is rather controversial. You need red blood cells, zinc, and selenium levels. If you just get the serum levels, it really doesn't tell you a whole lot. And then your HPA access, you can do that 4-point saliva test. There are urine tests you can do. There's the Dutch test. There's saliva tests. You can do spot blood tests. If you have ones that you're comfortable with, they're reasonably a reasonable testing unit, you should be okay with that. We'll do a lot of these. We'll do, there's the GI system is intimately involved with the thyroid, especially when the immune system is involved. 80% of the immune system resides in the small intestine. And so naturally we're going to get GI issues. Small bowel overgrowth is another problem. And unfortunately, you have to separate those two tests out, and they do get to be kind of expensive. Usually the stool testing is anywhere from $200 to $400. The small bowel overgrowth is another test. That's a lactulose test. You drink a little lactulose and you breathe into a bag, and it will measure the gases in there, methane and hydrogen that should not be there. You can do urine testing for bacterial or fungal overgrowth. You can do urine testing and serum testing for micronutrients. Here's a couple of tests that we use. This is the stool test on the left, and this is actually quite positive. It's a pretty extensive test. There's usually about 15 pages, and it takes me an hour to 2 hours actually to interpret this. This is just kind of a summary. Here, this is the SIBO test, and this is positive for the hydrogen here. They also, and it's slightly positive for the methane also. That should not be there. This is a micronutrient test, we like all of the micronutrients to be in the mid-range, mid-normal range, which is in the white. Anything in the blue, we're going to supplement. I had a grand idea that we were going to make custom-made vitamin packs for every one of these, but they got to be really prohibitively expensive, like $600 to $800 a month for those vitamin packs. It wasn't really practical. But you have here, you have B complex vitamins, you get antioxidants, you can get them in bundles. And so conventional therapy, again, I already mentioned that if the TSH is greater than 10, you're going to use levothyroxine, and they tell us to start at 50 to 75 micrograms per day. If it's greater than 4.5 but less than 10, you use levothyroxine if symptomatic, and if it's less than 4.5, generally treatment is not recommended, given the low risk for progression to overt hypothyroidism. You have patients that have a TSH of 4.2 and you tell them to go home, you're never going to see them again. And there's some entities over here. There's here the science-based medicine outfit says any treatment outside of just T4 is outside the realm of medicine. I kind of like this here. One size fits all. I mean, that's kind of the conventional wisdom. This is just to show you that the structure of thyroxine T4 versus synthroid. And the point is, you don't need to be a biochemist to see that these things are not the same. This is a hormone. This is a drug. The case for T4, the T4 naturally converts to T3, and the T4 contacts a cell in the bloodstream. It gives up its iodine atom to interact with those cells. With T4 to T3 conversions, the T3 conveys the metabolic message to the target cells. The real benefit is that this is a natural action and allows the body to perform a natural, body function. And it's what it's meant to do. All of these reasons are reasons for the T4 to not convert to T3. I'm not sure what age is considered advanced age. Raw goitrogen consumption, we'll talk about that in a few minutes. Make sure the patients do not take your thyroid medications with anything else. It should be first thing in the morning with a couple of sips of water, and I tell them not juice, not coffee, and not, nothing. A couple of sips of water, and ideally they should not be taken an hour before. You should have nothing to eat or drink an hour before and an hour after you take the medications. Those of us that are a little bit more mature and get up to go to the bathroom at 4 or 5 in the morning, I tell the patients, well, take it then. And then by the time you get up, to go to to get up for your day, the hours passed. Birth control pills. I had a nurse back in the 80s who was extremely religious, and she had adopted 2 daughters from Argentina, and one of them came down with severe Hashimoto's thyroiditis. She was 18 years old, and I didn't really know a whole lot about it back then. We sent her to the endocrinologist in our town. They sent her to the Mayo Clinic. Nothing worked. I mean, the girl, gained almost 100 pounds. She could barely get out of bed. She had all of the symptoms and she had positive antibodies that were greater than 2,200. They couldn't even measure them. And this went on for about 2 years. I used to take Friday afternoons off. I would do paperwork and then go home. One day, there was a knock on the door. It was a Friday afternoon, and it was Angela. It was my nurse's daughter. The one with the Hashimoto, the severe Hashimoto's. And she came in and she asked me. She says, "Dr. Clearfield, and it was Good Friday, as a matter of fact." I said, "Dr. Clearfield, Planned Parenthood's closed today. Could you renew my birth control pills for me? And I looked at her and I said, what birth control pills? And lo and behold, that's what it was. The birth control pills actually had thrown her into a really severe autoimmune reaction. And that went on for 2 years. And her mother was a very nice person, but she was very religious, and it was, not a, it was a taboo. And I never did tell her mother, but we got her off the birth control pills, and the immune issues went away within 2 months. So you have to ask about them: chemotherapy, radiation, heavy metal exposure, mold exposure. You can put on here also. Extreme exercise, over exercising can do it. Inflammatory issues can do it. Low iron, low hormones, testosterone and growth hormone, and different medications. Amiodarone is famous for this. It's a great drug for patient comes in atrial fibrillation. They give IV amiodarone for 48 hours, and it takes care of it. But for some reason, at least the cardiologists in our town want to put them on the oral amiodarone, which throws almost every patient into a type of hypothyroidism. If they already have thyroid problems, it really throws them into a thyroid crisis. I had it was my partner in my office back home in Wilkes-Barre who had this hypothyroidism, and he ended up like this, and he would end up going to the hospital. They would give him the IV amiodarone, they would give him the pills, and 3 weeks later he would be back in it again. I told him, tell him that not to take it, not to give you that stuff. But it kind of went in one ear and out the other. So amiodarone is sort of notorious for causing a hypothyroidism. Beta blockers, seizure medication, prednisone, lithium, and again, birth control pills, and synthetic, but not natural. Natural progesterone does not prevent conversion of T4 to T3. It's the synthetic ones, the progestins. T4 covers up thyroid deficiencies, but does not address the root causes. Some patients report that they never feel better on T4, somewhat improved, but they have lingering issues. And some of them have residual issues from the thyroid abnormalities. It doesn't really take care of the problem. And the depression, anxiety, hair loss, low iron. Some patients are misdiagnosed. They have high cortisol levels, which lead to a high TSH. So you have to be careful of that also. Make sure that you end up with a cortisol level, or at least that reverse T3, so you have a clue about cortisol when you're looking at thyroid issues. The conventional placement, the literature I found said 10% of the patients are unrelieved with just T4. I see a lot of them. To me, it's probably more like 50 to 60%, but maybe I see a skewed population. You optimize your TSH with your levothyroxine. If there are persistent symptoms, then we can add the desiccated thyroid. You can add liothianine, which is just T3, and it's an FDA-approved drug. Which will improve weight loss, mental health versus T4 alone. And patients in a survey preferred the combination T3, T4 combination versus T4. You get an improved weight loss and mental health versus T4 alone. Desiccated thyroid replacement is a natural preparation. This was around long before there was the synthroids, synthetic thyroid, and it contains all of these ingredients, usually T3, T4. It can have T1 and T2 in it. Some of the preparations have calcium or calcitonin and magnesium in it also. T3 is needed for adequate tissue levels. The brain and heart do not transport T4 into the cells. And when the optimal levels in the upper ranges of the free T3 improves or get there, when you get to the optimal levels, you get improvements in pretty much all of the functions. So depression, the immune function, it will lower high cholesterol, it improves bone health, it improves heart health, and it removes T4 only. Apparently there's some sort of pain syndrome that happens with just T4 only. desiccated thyroid extract versus porcine thyroid versus levothyroxine in double-blind crossover studies. The desiccated thyroid caused more weight loss, improved cognition. 50% or greater of the patients felt better on the desiccated thyroid. 19% of them preferred the T4. 23% had no preference. And it helps lower blood pressure, it improves cholesterol, it improves the metabolic syndrome and insulin resistance. T3 is dangerous for the heart. I mean, we're all told that. And that's true, in the quote unquote elderly. And if we throw the patients into atrial fibrillation, but if we optimize them, we really, that should be minimal to not a problem. It improves lipids, it improves congestive heart failure. It has a positive ionotropic effect. It's vasodilatory. Most of the patients with advanced congestive heart failure will end up, you're going to find, has altered thyroid metabolism. So patients who show up with heart failure, look at their thyroid. Patients that show up with GI symptoms, food sensitivities, also look at their thyroid. And it goes the other way. Mild thyroid disease raises cardiac risk. There's a twofold risk increase in heart attacks among women aged greater than 55 with subclinical hypothyroidism. Mild thyroid disease is well established as a cardiac risk, and as much as the same as cholesterol and smoking. Optimizing thyroid function normalizes the QT interval. It improves C-reactive protein and homocysteine, and it improves arterial stiffness and endothelial dysfunction. Low T3, and low T3 is defined here, at least in this study, as less than 3.1. It was the strongest independent predictor of cardiac death, even greater predictor than lipids or ejection fraction. So a couple of tips for desiccated thyroid. 1 milligram of desiccated thyroid is 1.667 milligrams of T4. So 60 milligrams of your thyroid combinations, NP thyroid, Armour thyroid are the two that are around still, the commercial ones, compounded, is equivalent to 100 micrograms of T4. The most symptomatic patients on T4 will show some improvement significantly after switching to a combination. Optimal dosing is when the free T3 is in the upper third of the normal range and free T4 is mid-range. Outcomes will show that we'll get complete removal of hypothyroid symptoms, mid-afternoon temperatures of 98.6. Patients that are hypothyroid usually cannot get their temperatures over 97.6. You get stable heart rates and blood pressures and improved energy. Usually when it fails, we have inadequate doses or excessive cortisol. So that you need to fix the cortisol also. Low iron can drive your body to make reverse T3 versus the free T3, the usable T3. And one of the Armour thyroid, the filler and the fillers and the coating was changed a number of years ago, and unfortunately there's some gluten and dairy in it. The patient could also be allergic to porcine or porcine products. So it would be a reason for a failure. Osteoporosis, it's one of these kind of myths. It's pretty rare. There's no decrease in BMD in pre or post-menopausal women or men. High-dose thyroid does not appear to be a risk factor for osteoporosis. The real problem is if we're only using T4 and you're not, applying the calcitonin, you're going to have to get it to the patient in another way, and that seems to be the real problem. So if you rely on levothyroxine, they're not getting the other nutrients that are generated. Thyroid hormones and gut peptides and growth hormone are interrelated. And so ghrelin, which is in the stomach, which is one of the pathways that generates growth hormone, is low in hypothyroidism and high in hyperthyroidism. So you're going to end up with correlations between TSH, free T3, free T4, and growth hormone. So what we're going to look at is the the causes of thyroid disease, and not just it doesn't convert from T3 to T4. And number one, and again, Hashimoto's thyroiditis is your immune system has been set off and looks at your organs as foreign, and this is the cause of the thyroid issues. If you don't address the immune issues, you're never going to get anywhere with the. You can normalize the thyroid function, but it's going to be a constant battle. You have to look at the immune system. We're going to look at GI immune issues, heavy metals, infectious diseases, the HPA axis, cortisol, there's also an autoimmune issues dealing with substances that are similar to iodine, which is halogens and fluoride, and the autoimmune, and then the medications. And we mentioned those before. Okay, so we need to find the cause. So there's a term called molecular mimicry, and so what happens is that the molecules that make up the thyroid tissue and the thyroid hormone are quite similar to casein, which is found in dairy, in gluten, which is found in grains, and a number of other substances, especially fluoride, which was put in the drinking water in major U.S. cities in the late 1940s.
Yes.
If you could mute yourself, that would be a help. Gluten, casein, and thyroid tissues share similar protein sequences. There's cross-reactivity occurs when the immune system misidentifies foreign substances as thyroid substrate, and that triggers the immune system. That's what we need to eliminate. The body looks at your own thyroid as foreign. These are the cytokines. We always look at them when we're trying to find herbal remedies and medications to combat whatever it is that we're looking at. So Th17, interleukin 6, 15, 17, 22, and 23. So when you find herbal remedies that combat those cytokines, we have a clue of how we can go about trying to attack this system. We also use immune modulators. This was a CME course, so I didn't use the names. Plant sterolins are a fat from plants. That's what they are. They promote a balanced immune system. They limit cortisol activity. They protect against negative stress responses. They oppose reactive oxidative stress. They modulate the autoimmune response in Hashimoto's thyroiditis. And we've had instances where patients have had a decrease in their antibody count load by up to 90%. And occasionally we've actually had them eliminated totally. It improves the T helper 1 to T helper 2 cells and downregulates overactive immune responses. This is not a CME, I think. So the one we like is called Magicare by Thorne. It's about $50 a month. It will decrease your thyroid antibody load by approximately 50% per year. So patients who show up with a TPO of 200, in LabCorp the normal is 34. In 1 year it'll be down to 100. In 2 years it'll be down to 50. In 3 years it'll be down to 25. That's actually a long time, but if you don't address it, what will happen is that the thyroid antibodies will continue to destroy the thyroid tissue, and within 5 years of it being detected, the thyroid will be totally dormant. It won't work at all. So it behooves you to jump on this. Some of the endocrinologists are coming around to this now, using this. There's another one called Wobazyme. There's lots of Wobazymes. It's made by Douglas. This is Wobazyme N. And this is actually a systemic enzyme formula, and this will also decrease thyroid antibodies by about 50%. It's not quite as potent as Magicare. It's a lot less expensive, though. It's only about $17 a month for the Wobazyme, and we'll interchange the two of them because, again, like everything else, there's some supply issues. There's lots of Magicares. They should all work. You want to use one of the immune modulators. So we use this. This is our go-to, and we always do a whole hormone panel And a lot of times patients will have a lot of supplements and medications or hormones, that we want them to begin with, but sometimes they're reluctant, or money's an issue. We always tell them, if they have positive thyroid antibodies, this is the most important thing. It says if you can only do one thing, it would be using these plant sterolins. They are very effective, and if the patients use them usually twice a day, they are very predictable. They do work. Here are the references for the plant sterolins, and you can see, I got ding. You always when your patients come back to you and say, my doctor said there's no evidence of quote unquote plant sterolins, here's your evidence. There's 51 references for that. That should be plenty. You can use the plant sterolins for any autoimmune diseases and any one of these. And usually when you have one autoimmune issue, if it's not addressed, it will morph into the others. Like I said, in the thyroid, it's going to morph into the GI system. They'll usually come in with 2 or 3 issues to begin with. So Crohn's disease, ulcerative colitis, you can see psoriasis, vitiligo, and also, I don't have one here, Sjogren's syndrome, but that's also commonly associated with thyroid autoimmune issues. The GI issues, it's what you eat. I like this quote from Mark Twain. It kind of sums up everything we tell folks. The only way to stay healthy is to eat what you don't want, drink what you don't like, and do what you'd rather not do. I think that kind of sums it up quite nicely. So the GI connection, I already told you, 80% of our immune system resides in the GI tract, and without a healthy GI tract, it's pretty impossible to defend against disease. The causes, again, are standard American diet, high fat, high sugar, and oils, seed oils, lectins, everything that we're taught about diet is sort of the culprits here. Sleep deprivation, alcohol, chronic stress, liver toxicity, food sensitivities, all contribute to poor GI function. Also, this is a food sensitivity test. I just picked this one out, and you can get them. I've seen them actually on Groupon for $27. Some pretty reliable tests every once in a while. They usually go into it's usually about $1 an item. So the one we use has 184 entities. It's $184. And basically we tell you, it's pretty clear. Patients, these are the things that you're going to react to. Now, this is not food allergies. This is not like a peanut allergy where if you eat peanuts and you're gonna have a breathing issues and an emergency. It's not that. It's usually delayed symptoms. Gluten, no matter what the New York Times says, is a major stressor of junctional walls of the small intestine. It's a protein, a combination of it's barley, rye, and a combination of wheat and rye called trilicate. It loosens the openings and allows toxins, microbes, and food particles into the bloodstream. And it will cause systemic inflammation, autoimmunity, and you'll end up with food intolerances. This is our so-called leaky gut. Zonulin is the sort of the adhesive between the cells in the small intestine, and you can actually measure zonulin levels. And it's still labeled as experimental, but it's pretty safe to bank on that when you get one of your GI tests. The body fights back when these large particles get into the bloodstream that don't belong there, and again it sets off the cavalry, your antibodies. To heal the leaky gut, this is your 4 R's. I'm not going to read all of this, but so you want to remove the offending agents. Alcohol and gluten are the big ones. Sugar and dairy. You want to replace it with high fiber foods. Oily fishes, salmon, mackerel, herring, mushrooms, anti-inflammatory herbs and spices. You can re-inoculate with prebiotics, probiotics, kimchi, fermented soy, fermented beverages. And then repair, we like L-glutamine. It comes in a combination with deglycerinated licorice. You can use deglycerinated licorice in a pill form or in a chewable for upper GI, GERD, and heartburn type issues. Mastic gum and aloe vera will coat the stomach lining. And polyphenols are those anti-inflammatories, quercetin and curcumin. They come in combinations, and they work quite nicely. Also for GERD, we'll use zinc carnosine at times. This is kind of just a chart that shows you the same thing, the 4 R's: remove, repair, restore, replace. And also we're going to use some digestive enzymes. Goitrogens. So these are foods that slow the thyroid down. And it's been bandied back and forth for quite a long time, because cruciferous vegetables are stuff that we tell patients to eat because it's good for them. It will calm the menopausal symptoms. But in the thyroid, patients with thyroid issues, it will actually slow them down. So the consensus is that these foods, if you have them cooked, it will cook out the goitrogens, the chemicals that slow the thyroid down. So we have some patients, so there's spinach on here. We had some patients who they have spinach salad every day for lunch, and they have thyroid issues, especially the immune issues. So we have them, well, they won't really want to cook spinach, but they're not going to die, but if we could slow it down, maybe skip one day a week, that would be a help. They sometimes make smoothies. They'll put the spinach in there, and again, if they cook it, it usually cooks out the offending chemicals. And there's here broccoli, cauliflower, kale. These are all things that we tell patients that are good for them. Especially in the menopausal issues, but it will slow them down. Have them cooked. I don't think anybody's going to eat raw sweet potatoes. I could be wrong. So this list here are again, this is just a little bit of quote unquote food for thought. Things that may help: bone broth, which helps restore the gut barrier; fermented vegetables; shellfish, and fishes that are high in omega-3 fats; and organ meats that contain micronutrients. Vitamins, as I showed you before on the chart: vitamin A, vitamin D, enhance the immune system. Iodine and selenium help convert the T4 to the T3. Glutathione is a liver detox agent, and it helps promote healthy T regulatory cells. And B vitamins 3 and 6, vitamin C, magnesium, iron, copper. These are all nutrients that will aid the thyroid in functioning properly. If you want to do an elimination diet, instead of doing the food sensitivity test, this is kind of the poor man's version. Again, limit the goitrogens to cooked, 3 to 6 servings per week. And what you do is you eliminate one of these items at a time, usually anywhere from 1 to 2 weeks, and then reintroduce them if they have reactions to them, because again, these are delayed food reactions. It's 48 to 72 hours delayed. If you have delayed food reactions, then you'll know that these are foods you need to stay away from. Nightshades are pretty well known. So those are potatoes, tomatoes, eggplants, and peppers. Those are inflammatory foods for pretty much everything. So pretty much everybody needs to be careful of them. And there's certain nuts you may have sensitivity to walnuts, but not peanuts, or peanuts and not hazelnuts. So again, an elimination diet if you're nut sensitive. Brazil nuts, 2 Brazil nuts usually a day, contain enough selenium to continue the reaction that you want. So that's a way to go. I found this. This was a quote unquote snack, which was written about in the early 1950s by the German, West German Minister of Health. Her name was Joanna Budwig, and she took oil, usually olive oil, and she mixed it with sprouts and chia seeds and some dairy, either cottage cheese or goat's milk, kefir, and some flaxseed oil, turmeric, and black pepper, and mixed them all together. Kind of use that as a snack. and it's kind of a, a sort of a healthy snack, but it would help with gut healing. Added some berries and fruits, and pumpkin seeds, sunflower seeds. The formula is right there. Stay away from peanuts, and it helps with to help heal the GI tract. Again, she wrote about this in 1952, so this is not anything that's really new. Things that are good are your good fats, your coconut oil, avocado oil, fatty fishes, ghee, proteins, fish and chicken, fruits, the berries, blueberries, blackberries, strawberries if they're cooked, apples, seeds, chia seeds, flax seeds, almonds, and walnuts if you don't react to them. Stay away from gluten, sugar, trans fats, processed foods, dairy, soy, and corn. That's your diet. Heavy metals. A child born in the year 2000 was exposed to 80,000 chemicals that didn't exist in 1970. And we all know about glyphosate. We really don't need to probably go through that again. PCBs will impair brain function. Triclosan is present in soaps, toothpaste, bath towels, and in utero can cause some limb deformities. So phthalates, that are in fragrances, perfluorooctanate is in nonstick cookware, microwave popcorn bags. These are all thyrotoxic. These are a whole bunch of disorders that have been linked to heavy metals. And so sometimes we need to look at heavy metals. I had a guy who ate sushi 3 times a week, and he had very high mercury levels. We had to do chelation on him to get rid of it. Nitrates are in fertilizers and processed foods, cured meats like hot dogs and bacon. Spinach and celery naturally have naturally containing nitrates, and percolates are in fireworks and fertilizer. So, it's nearly impossible to avoid it. Avoid it as best you can. HEPA air filters wherever you live and wherever you work. Water filters, organic grass-fed meats, fishes with lower mercury levels, which is salmons, the oily fishes versus say tuna. Try to avoid processed and cured meats. Use organic skin products, and if you have any mercury fillings, they should be removed. And remember to find somebody who knows what they're doing, removing them. A liver detox profile might be intravenous glutathione. Usually glutathione in an oral form, it has to be liposomal, it has to be fat coated. N-acetylcysteine will be a glutathione precursor. Milk thistle is another liver detox agent, and you can use a high dose vitamin C. We do it in an IV form. If you're going to use intravenous glutathione, you have to separate it from the intravenous vitamin C. Intravenous vitamin C will deactivate glutathione, so keep that in mind. Infectious agents, there's some of them that will will create a immune deficiency. Epstein-Barr is probably the worst. So these kids who get mononucleosis in their teens all of a sudden start showing up 10 years later with immune thyroid issues. Multiple sclerosis, chronic fatigue syndrome, fibromyalgia. You need to look at Epstein-Barr, herpes simplex types 1 and 2. Yersinia is usually from food poisoning. Uncooked pork, foods that are left out. Hepatitis C comes from blood and body fluids. H. pylori, is a bacteria that attacks the stomach lining. We've had had patients with even long-standing H. pylori that we've treated. We've done it the medical model way with the triple antibiotics, and actually have had about 15 cases, not very many, but 15 cases where we treated the H. pylori and the thyroid immune system reverted back to normal, and they were off of all of the thyroid issues. The thyroid symptoms went away. Lyme disease. And another in there, and then mold and mycotoxins also, which is not on there, are all can all relate to thyroid issues. Some remedies here, real quick. I'm sure you all have your own favorites. Colloidal silver, and vanciclovir plus Celebrex is a good combination. There's the dose there for about 28 days. And humic acid monolaurin is a combination, is a natural antioxidant and a natural antiviral agent. It binds to positive and negatively charged ions and boosts the immune system. It contains olive leaf, which is a known antiviral, antibacterial, and antifungal agent. We've used peptides. We know that everybody here is big on peptides, thymosa alpha-1 and thymosa beta-4. I think they're coming back. You know, they got scarce with COVID and all, but I think they're coming back. And epithalon is another one we can use for viral infections. For bacterial infections, of course, antibiotics, GI tract flora, pre and probiotics, and even a little bit of chicken soup and vitamin D doesn't hurt. We like BPC 157 orally and also sub-Q. We use that. We actually use that as part of our weight loss formula with semaglutide, and it's quite effective in combating bacterial infections. And now we're going to talk a little bit about cortisol and stress hormone. Historically, it was written about originally in 1881 by a doctor in New York City named George Miller, and he termed it as what we call adrenal fatigue now. He termed it neurasthenia, and he described it perfectly. And he went from a nervous dyspepsia, a sick headache, chorea, which is shaking, sleeplessness, hypochondria, hysteria, all the way up to epilepsy and insanity. It was written about, like I said, in the late 1800s, and it was rumored that Theodore Roosevelt and Frederick Remington, who was a painter of the Old West, suffered from they both suffered from this neurasthenia. The cure was a withdrawal from modern life to rest in a simpler lifestyle. And there were critics even then. You know, today we say that there's no such thing as adrenal fatigue. If you type in adrenal fatigue in a search engine, you'll find all sorts of, the endocrine authorities say it doesn't exist. You either have too much, high cortisol, which is Cushing's disease, or low cortisol, which is Addison's disease, and there's nothing in between. Well, the adrenal fatigue, to me, is what's in between. The critics stated that it was a function of urban life in the late 19th century that produced, quote unquote, a pathetic, pampered, physically and morally enfeebled 97-pound weakling, unworthy of successors to the stalwart Americans who fought the Civil War and tamed the continent. So I guess that's kind of politically incorrect statement also. So neurasthenia, HP axis dysfunction, burnout, stress hijacks your normal hormonal responses and redeploys the HPA axis resources to combat the evil of the moment. Other functions of the HPA axis, digestion, the immune system, thyroid production, are temporarily put on hold or are slowed. In an ideal world, stress is resolved or passes quickly. So, back in the day when we were hunting mountain lions, and whoever one got to eat and the other one got to be eaten. So you come across the mountain lion, your stress hormone would shoot sky high. That's your fight or flight response. And then once the danger was over, it went back down to simmering. Sort of like the computer programs you have on your computer that are down at the bottom right-hand corner. They're sitting there. If you need them, you click on them. They pop up, you use them, and then you click them back down. You don't want them taking up the whole screen. But we don't live in an ideal world. Stresses are, continue to build up, and the stress hormone cortisol never goes back down to its low-level state where it belongs. The body's flooded with cortisol, driving the HPA axis to make even more. Eventually, the HPA axis can't keep up with it, and we get this burnout type situation. High cortisol levels signals to the brain to lower the production of stress hormones. Unfortunately, the thyroid is also caught up in that. When you have high cortisol levels, every other hormone is diminished. When you add hormones, some of them, like thyroid, testosterone, estrogen, pregnenolone, will increase cortisol, but other ones like thyroid and insulin will decrease cortisol. So if you have a high cortisol level, your enzyme, your hormones are going to be lower. If you have, but if you're treating patients with any different types of hormones, you can sometimes get an increased cortisol level, sometimes a decreased cortisol level. Stress hormones affect enzymes that convert T4 to T3. There's that T4 to T3, and it converts the T4 to that inert reverse T3. And so we can measure that quite easily with our thyroid panel. We don't have to do a separate saliva test with that expense, and we can get an idea of where it goes. And I use that quite extensively. I used to do the saliva test on every patient. I probably don't do it on 10% of them now. It just really isn't that necessary. Cortisol is the only hormone that increases with age. It's made in the adrenal glands, and when you're stressed, it elevates, and again, it's supposed to come back down, but it doesn't. Overbooking is an issue. Where you're doing whatever it is in your office, and you got 3 people waiting for you, and another one shows up and says they have an emergency, and all of a sudden, your whole day is shot. Some functions of cortisol: it balances the blood sugar, it helps control weight, it turns over bone, it improves sleep, and it creates protein synthesis. It will stabilize moods and thoughts. It will influence the testosterone estrogen ratio. It will influence DHEA and insulin. It affects pituitary, thyroid, and adrenal systems. It is anti-inflammatory. Cortisone elevators include stress, poor diet, poor sleep, inflammation, depression, high progestin, not progesterone, but progestin, and excess exercise. Elevated cortisol consequences: we have increased osteoporosis risk, morning fatigue, irritability, sugar cravings, shakiness between meals, memory loss. Here is kind of a schematic of the effects of excess cortisol on the body, and you can see it creates quite a not a very nice picture here. Just more consequences: higher blood pressures, higher cholesterols, higher blood sugars, low energy, night sweats, binge eating, sleep disturbances, impaired conversion of T4 to T3. High cortisol levels equals thyroid resistance. Elevated cortisol levels release inflammatory cells. Cortisol exhibits a strongly inverse temporal association with ghrelin. Ghrelin, remember, is part of the pathway that creates growth hormone. So high cortisol levels will inhibit growth hormone. It will also desensitize the thyroid receptors to the thyroid hormone. And like diabetics who don't respond to insulin, you might have adequate thyroid hormone, but it becomes insensitive. Low cortisol, fatigue, low blood pressure, sensitivity to light, insomnia, digestive issues, low blood sugars, and poor libido. Poor immunity, emotional paralysis, poor wound healing, alcoholism, and drug addiction, unresponsive hypothyroidism, and a feeling of being overwhelmed. And the hormones, like I said, estrogen will increase will increase cortisol. Cortisol will diminish estrogen, though. So elevated estrogen, elevated cortisol, decreased thyroid, decreased growth hormone. All of the other hormones are, like I said, are decreased with elevated cortisol levels. That's chronically elevated cortisol levels. Testosterone will initially, I mean usually just 2 to 4 weeks, will increase slightly to begin with chronic stress. Again, the saliva test is kind of the gold standard. This is a normal saliva test. You get a high level reading in the morning. That's your cortisol activating response here. And then it falls off by noon, and it kind of just meanders on down, and it should just be there just in case you need it. This is normal. This was Tom. Tom is a chiropractor. He was 70 years old. He came to my office. He has told me he had 8 kids. The youngest 2 are autistic. The 2 younger, the numbers 5 and 6, had Down syndrome. His oldest son burned his house down with his wife in it, and she died. And he was obviously having a lot of stress. So this was his cortisol excess pattern. As you can see here, this is quite high. And we'll go through the treatment protocol, I think, here in a few minutes. But we went right to, if you know the algorithms, we went right to Cortef. I didn't fool around with the herbal remedies. I mean, he was kind of in dire straits. This is Tom 6 months later, and he was telling me he was having trouble getting out of bed. So you can see it was quite a dramatic turnaround, and he did much better. His total cortisol levels were within the reference range for this lab here. He had a little bit of agitation in the afternoon, but he was actually doing quite well. Obviously, we can't fix the issues that he had to deal with, but we were able to get his energies to the point where he was able to take care of them. This is just another 4-point saliva test. This is a gal who basically she's tired all the time. She can't get out of bed in the morning. She has no energy. And then our job here is to sort of bend this curve up here. Just use that as an example. In summary, so adrenal fatigue, you're going to look at the thyroid, you're going to look at DHEA and cortisol levels, progesterone and testosterone. In the nutritional area, you need to look at magnesium, B12, all of the B vitamins, coenzyme Q10 and vitamin C, the toxins, bowel and gallbladder issues, and heavy metals, and the body, the blood vessels, muscle and bone, and again, a mind-body connection. The first step is relaxation techniques. We introduce the anti-inflammatory diet. We make sure the patient's exercising and sleeping. We find out what stress reduction techniques they like. So if they like yoga, that's great. If they don't like yoga, we don't tell them, you have to do that. Infrared saunas work very well. Sometimes you have to do lifestyle changes. I mean, it's pretty rare, but in today's day and age, but sometimes it has to be done. We replace DHEA if it's low. DHEA it sort of buffers cortisol. They're sort of inversely related to each other. And so if you have high cortisol levels, you're going to have low DHEA. If we replace the DHEA, it's going to lower the cortisol levels. We use adaptogenic herbs. The ones we like, there's usually a combination of cordyceps, rhodiola, and ginseng. Cordyceps, rhodiola, and ashwagandha, sorry. And eleuthero, which is Siberian ginseng. There's any number of herbal companies that are supplement companies that'll make combinations. They usually throw in some vitamins with it. Find one that you like. Those are the main ingredients, though. Can I have some calming herbs? We like some of the Bach flower remedies for that. If there's high evening cortisol, we'll add in some phosphatidylserine, even some licorice. So these are some of the nutrients that you may want to look at with if the adrenals are high: zinc, selenium, copper, sodium, manganese, and B and C vitamins. If the adrenals are running low, again, stress reduction techniques, the adaptogenic herbs. Remember, adaptogenic means when your energies are low, the herbs will help bring the energies up. If the energies are high, it's going to bring them down. If those don't work, usually after about 6 months, we'll go with adrenal extracts and some calming herbs. We use some licorice also. That's not the stuff you get in the movies. You stay away from licorice if the patient is hypertensive. And sort of our last resort, we'll go with hydrocortisone or Cortef in a low dose. You usually won't get side effects from Cortef if you keep the dose under 30 milligrams a day. Now, that's not prednisone, or methylprednisolone. This is hydrocortisone. It's just the pure stuff. I usually start at 7.5 milligrams in the morning and in the AM, 5 milligrams at noon, and 2.5 milligrams no later than 4 to 5 p.m. at night. Iodine is necessary for production of T4. Iodine must come from the diet. It resides in the ocean. Usually you get it in seafood and seaweed. And it's added to, why it's added to salt? So in the late 1940s, there were some experiments done by two scientists at Berkeley, University of California at Berkeley. They took radioactive iodine, injected it into rats, and of course killed their thyroids. They extrapolated that to food grade iodine, and they convinced the FDA at that time, whatever agency that was, to take iodine out of the food supply in 60 major US cities. Well, it didn't take long. It took about 5 years before we had our major, a major immune hypothyroid crisis, because added to that, was in the same 60 US cities, fluoride was added to the water supply to help protect teeth. So iodine and fluoride, as you know, are halogens. They're in the same sort of chemical composition. And so our bodies mistook the fluoride for iodine until it realized that, hey, we don't have the right stuff here. And it sent out the cavalry, our immune system, to go and kill it off. So there was a major Hashimoto's thyroiditis crisis in the early 1950s. And so, you know, politicians, as you know, never admit that they've done anything wrong, but they had to fix this. So they decided that they looked at what Americans ate too much of, which was sugar and salt, and they just picked salt. They put iodine in the salt. That's where iodinized salt came from. It could have been iodinized sugar. So this was called the Wolff-Chaikoff effect. You know, even though they did the radioactive iodine and poisoned the rats when they used natural, and they extrapolated it to food grade iodine, they were never able to repeat the experiments, but it didn't seem to matter to them. You know, they were right. The correct interpretation was that iodine sufficiency of the thyroid gland was achieved when serum organic iodine levels were at 0.2. It's not that it became, you know, when it was raised to 0.2 that it became a poison. So again, they didn't measure the thyroid hormones in the rats. In fact, they kind of criticized the rats because they couldn't repeat the experiments with food grade iodine, and that was going to be their claim to fame. And so they publicly chastised the rats as being rodents non grata, and they said that the rats just weren't cooperating with the new normal. They refused to become hypothyroid when the food grade iodine was given to them in really high doses. Here's a source for that there. It's kind of amusing if you look at it. In 1964, iodiphobia became a thing, and there was actually a movie called Dr. Strangelove, and in the background story in the movies, so the Air Force general locked out the U.S. Air Command and ordered a nuclear strike on the Soviet Union, and the Air Force general was convinced that the fluoridation of the water and removing of the iodine was a communist plot to be able to take over the U.S. without having to fire a shot. That was the background story of that movie. That was starred Peter Sellers. He played 7 different characters in it. So, and he said, if you want to destroy a nation, remove the iodine from their diet. It's that simple. Called it a form of bioterrorism. So iodine has effects on the estrogen, progesterone, and menstrual irregularities. When we took iodine out of the food supply, there was a big bump in breast cancers. There was a big drop in serum estradiol levels and a marked increase in serum progesterone. A decreased menstrual blood flow, and there was a marked increase in breast cancer and endometrial and ovarian cancers also 5 to 10 years, about 5 years after the removal of iodine from the food grade. Iodine, again, is a halogen. The other halogens are fluoride, chloride, and bromine. Those of us are old enough to remember white bread that was delivered to our home, that in the crust was bromine. And then the fluoride I already talked about, and iodine. And so they're chemically similar to each other, and that molecular mimicry would take place, and that would set off the autoimmune cascade. So again, you have to look at those entities also. Chlorine is in pesticides and paper products. Bromide is in flour products, usually white bread. Remember, the citrus flavored soft drinks became a thing. They had no calories in them, but they had bromide in it. Chemical additives were put in the municipal water supplies, pesticides, dyes, lead fuel additives, and over-the-counter cough syrups. Fluoride is in all of these things: toothpaste, infant formula, sodas, teas, wine, insecticide, SSRIs, and antiviral medications. The RDA is 12.5 milligrams per day. Iodine will improve the immune function, is anti-carcinogenic. It detoxifies lead, heavy metals, and decreases singlet oxygen formation, the major cause of oxidative damage to DNA. So we've come to the consensus that we're going to use micro doses You use homeopathic doses like 150 to 225 micrograms. That seems to work out pretty well. If you give 12.5 milligrams of iodine, you're going to get hyperthyroidism. You're going to end up with some kind of nasty issues there. Seafood and saltwater, fresh fish have a good iodine production, and like I said, the 12.5 milligrams, which is the sort of the RDA dose, can lead to hyperthyroidism and hypothyroidism. So tiny doses will stimulate your body to make enough iodine. Other nutritional issues: vitamin C, vitamin B, zinc, protein, magnesium, selenium are all necessary for normal thyroid function. Adequate protein. Drugs to watch out for: again, we talked about amiodarone, beta blockers, dilantin, prednisone, synthetic progesterone, the benzos, and lithium. We've come up with a 100-day thyroid rehab program. We do our history and physical. These are the labs that we'll do. And like I said, I don't do this very often anymore, the saliva test. We'll look at whatever is, so if homocysteine is high, greater than 10, we'll use methylated B vitamins. If the liver enzymes are showing some stress, we'll use a liposomal glutathione or N-acetylcysteine. Again, vitamin D, we want the levels to be between 50 and 80. Of C-reactive protein, if that's greater than 1.0, we'll use fish oil or krill oil or flaxseed oil if the patients don't want to use any type of fish. Curcumin we'll use for if there's joint pain. For sleeping, we'll use magnesium taurate, 100 milligrams. We couple that with vitamin D, and we'll also use some melatonin, 3 milligrams. So we'll give them all three of those 2 hours before bedtime. Remember, melatonin is not a sleeping pill. It resets your daily rhythm. Probiotics, at least 40 billion units. Now we're using the spore-based probiotics that seem to work much better, and also Saccharomyces boulardii. Plant sterolins, if the antibodies are positive, even by 1 point. So the Quest, which is the other big lab in our town, the TPO 0 to 9 is normal. If I get a 10, I'm gonna jump on that, because you can save your patients a lifetime of misery by taking care of it. That's usually in our initial foray. We'll have them come back in 2 to 4 weeks. We'll start them on an elimination diet or the autoimmune protocol. We actually have it online. We send them recipes every day. We will do I showed you the micronutrient testing, food allergy testing, and the elimination diet if necessary. We'll add in, again, if they have adrenal support, we'll use the adaptogenic herbs, vitamin C, selenium, magnesium. If they have elevated cortisol levels with low DHEA, we'll add in some DHEA. If they have some cognitive issues, we'll add in some phosphatidylserine. We do measure now pregnenolone levels, and we'll use anywhere from 30 to 60 milligrams of pregnenolone. So 90 to 110 is a sweet spot on the lab for pregnenolone. Anything under 70, and we always ask about memory. That's the hormone of memory. If they have their memory issues, we'll add in pregnenolone. You can get a 100 milligram tablet. You can get 90 of them for about $15 from Life Extension, so it's pretty inexpensive. 30 to 60 is the usual starting dose. Low cortisol, low DHEA. Again, we'll give them a little bit of DHEA. We'll give them some pregnenolone. We'll add in Cortef if either the saliva test is positive or they have severe sort of adrenal fatigue. And so high cortisol in the AM, we'll add in. Here's the formulas right here. I think this was a repeat. Phase 3, so this is 45 days out. If we need to do some GI testing, we will always want the patients to be gluten-free, and I tell them it's a Judge Judy deal. It's a yes or a no, not 80%, not 90%. They're either gluten-free or they're not. And we're pretty strict about that. And the patients really do feel a lot better if they stay away from gluten. We'll repeat the thyroid antibodies and the thyroid function. If they need food allergy testing again, we'll do that. If they need the GI test, we'll do that again. SIBO, we'll do that. Now, we only do it once. For mold, there's some mold tests now that we use. There's this VCS aptitude test. You can do this online for free at survivingmold.com. It's a visual test, and it's kind of a screening. If that becomes positive, we use now we like Dr. Andrew Campbell. I don't have it on here. He's from mymycolabs.com. He states that mold has to be diagnosed through serum tests, that the urine tests are not accurate. C4A, when that's low, is indicative of a mold issue also. GI issues, a lot of times the patients have been on PPIs for a long period of time. Remember, they were only designed to be used for 2 to 4 weeks, not 30 years. A lot of those patients have low stomach acid, which is similar in symptoms to high stomach acid. So we can add in some betaine. Again, probiotics, L-glutamine for lower GI symptoms, omega-3 fatty acids, and vitamin D. Specialty things. So again, here's remedies for blastocystis, candida, SIBO. Here are the remedies that we have for that. Chronic sinusitis. Again, look for yeast there. We make this iatroconazole steroid nose spray. We use thymosa alpha-1, thymosa beta-4 peptides for mold. We'll use Sporanox now, 100 milligrams twice a day for up to 6 months, which is way longer than the books tell us to. But sometimes you need to do that to keep it away. Saccharomyces boulardii, caprylic acid is a good supplement or herbal anti-inflammatory or antifungal. Patients with Epstein-Barr, again, Valglan cyclovir plus Celebrex is a good combination. I got that from Jacob Teitelbaum. That's his formula. Humic acid monolaurin is is actually from coconut crystals. Is a antiviral. Cordyceps, olive leaf, N-acetylcysteine, IV vitamin C. You'll have these here. We can get you these charts. Repeat testing, and then take it from there. And then we always hold it in abeyance. And this is a whole nother lecture, and we've done this before. Low dose naltrexone. Again, for Hashimoto's thyroiditis, you're going to use a lower dose. We usually start at 1 milligram. We treat the patients for a week. Then we give them 2 milligrams and then 3 milligrams. We increase by 1 milligram per week. If they're okay, then we'll use a 3 milligram. That's usually the top dose, not 4.5, which it is for other neurologic entities with low dose naltrexone. Also, MS, multiple sclerosis, you don't want to go over 3 milligrams for low dose naltrexone. The only time we ever go higher than 4.5, just as an aside, is with gynecological issues. We'll go up to 9 milligrams. But we start at 1 milligram. We make 1 milligram tablet. We have much less side effects with the tablet than the capsule. Remember, these are compounded. Use 1 milligram tablet, then have them take 1 for week 1, 2 for week 2, 3 for week 3. Side effects to look for are insomnia. We usually dose it at night. The low dose naltrexone works for about 6 hours, and it builds endorphins and it's anti-inflammatory. And it only lasts about 6 hours, but about 10% of the patients will keep them awake. So then we'll have them use that during the daytime. There's some patients will get some nausea from it. I rarely do have somebody who can't take it. We'll usually even half the dose until they get used to it. Usually not more than a week, and they're usually okay with it. And about 20% of the patients end up with vivid dreams with the book. It's what the books call it, with nightmares. And so that you'll get that occasionally. Those are really the only side effects that you get from the low dose naltrexone. It is quite potent, and use that with the Modicare with your plant sterolins, you're going to see a vast improvement in the immune function. Make sure their thyroid function is adequate. We like the TSH at 0.8 to 2.0. We like the free T3 in the upper third of the normal range, so about 3.4 to 4.2. That's kind of our treatment goals. Here's a chart of conventional versus integrative models for treating Hashimoto's thyroiditis. As you can see, we're much more complete over on the right than the left. Here are all the references. I always do this for you so that you can, when you say, my doctor says there's no evidence of, so there's 77 references just in this lecture here.